Good afternoon, everyone. Um, it's Tuesday, 2 p.m. Anesthesia rounds with me. So I welcome all of you. I understand quite a few are also on evacuation. As you can see, I'm on evacuation myself, staying in a hotel room. So it's expected that quite a few cannot make it. And what I will do is I will post this video recording for those who cannot make it for this session in the Elantra. So uh, those will be readily available for you guys. Let me just take my phone on the silent mode. So it's an interesting year, isn't it? Like COVID and fire. What is next now? Surprise me. Maybe a third world war. Hopefully not, but yeah, election would be another surprise. Who knows? But anyway, we were in the middle of doing the last slides last week, and then I didn't realize we had running out of time because I thought we didn't have any follow-up session, so that was my oversight. But essentially, that slide, I think I literally covered 90% of that that last bit. What I was going over was all ideally injectable anesthetics would have, ideally, that's the important keyword, reversal agent. But in reality, I would say 75%, if not greater, we don't really have a specific reversal agent. But we still can reverse the depression using non-specific antagonist. And that's where we got cut off when we are going over that part. So it's a doxapram, drugs like a doxapram. It's not really antagonizing like adipamazole will antagonize dexmedetomidine, naloxone will antagonize morphine, flumazenil will antagonize midazolam, and so on. So it's not specific antagonist. It just makes the patient more alert, less depressed, and they are able to breathe better, and their blood pressure is also helped better. And the catch to that is doxapram on its own sometimes can, if you do not dose right, really cause some disturbing stimulation, like too much of respiratory effort and tachycardia and elevated blood pressure. And at that point, you wonder whether it was just shifting the pendulum back to the other extreme, and whether that will be detrimental to their cardiopulmonary system. By the way, does anyone here didn't receive my email reply for whatever you send the questions or whatever you ask me? Then I apologize upfront, and let me open up the floor so that I can address that now. Right, good. Silence is good news, at least out of 24 of you, other than a couple of you who may have to miss this. I address that. And hopefully I address everything, including the two who couldn't make it today. Whatever that is. So so that was it. And just to recap, we studied off some anesthesia topics, including their equipment and induction, well, I should say injectable agents that was broken down into pre-anesthetic drugs and induction drugs. So now we have left with inhalants, which are also maintenance, the preferred choice of a maintenance drug, really. And there are good reasons for why inhalant became the preferred choice. And we will definitely go over it as I can share the PowerPoint. If I can share it, I may. Okay, let me see if I screen sharing. No, this must be. I hope, raise your hand if you are able to see the PowerPoint on the topic today, or thumbs up. Yeah, good, thank you. You see the methylphane, halothane, isoflow, sevoflow there. And methylphane is a methoxyfluorine. Halothane is halothane, basically. It's a generic name, same as trade name there. But these drugs are obviously old, and they're not used anymore. The other drug, isoflurane and sevoflurane, are the two most commonly utilized, at least in veterinary medicine. They have one additional drug in human medicine, as well as for equine practitioners. They also favor to use drug called desflurane. It's another newer kind, like sevoflurane. So if you look at the slides, pictures from left to right, that's the also chronological order how the drug was released to the market. Methoxyflurane, 1960s, 70s, halothane, 1970s, 80s, and then isoflurane, 80s and 90s, and sevoflurane is 90s and 2000 and onward. So why then there are these newer at the time drugs needed to be developed and released to the market? That is because we studied off a drug called ether. Actually, all the drugs here listed, they're kind of ether. We modify the side chain of ether, and we call them also another name like a halogenated ether, because nuclear bomb technology was actually utilized to develop halogen compound. So that, I guess that's one good thing from technology that mass murdered many people, in a way ironically contributed to save life. So that all was lost. Anyway, so here, basically a cartoon humoring about the leg get chopped off, but then the patient is, screaming in pain. So, before the development of anesthetic, what it would have been like to have a very painful surgery. It's excruciating pain to the point the patient will go into the shock and cardiac arrest. Actually, they will not die of the blood loss, but the pain-related cardiac dysarrhythmia or cardiac arrest. that was more likely cause of, because before they lost all the blood, not um, getting well controlled, that contributed to the mortality or morbidity. It was more of the pain. And you might have remember the James Young Simpson and associate this cartoon also, that early pioneers tried to develop a useful drug, and this Scottish doctor and his colleagues were critical in bringing forward the alternative to ether at the time, chloroform, as also useful anesthetic drug. But remember William Morton, famous trial of ether at Harvard or Massachusetts General Hospital in 1846, turning the medicine, the history of the medicine forever from that point on. So inhalant drugs needed to be precisely controlled because they are fairly toxic. Toxic, what I mean by toxic is that very, very cardiopulmonary depressant. Pulmonary depression is not a big deal when the animal is or human patients are intubated. You can always support ventilation, but cardiovascular is a much bigger deal. You cannot like begging, supporting ventilation. You can do that when the patient gets bradycardic and hypotensive. It's a lot more challenging to correct them, and they obviously need a very, very controlled, precise anesthetic delivery using what we call agent-specific vaporizer. You cannot mix this desflurane vaporizer by adding like a sevoflurane. They are all agent-specific. It's absolutely not permitted. In fact, if you do that, you can kill the patient. So it is just saying we are actually intoxicating our patient, but in a way they are reversible, fortunately. If it is not irreversible, then you run into a big problem there. So unlike injectables, inhalant anesthetics obviously have its own unique properties that will make our usage of safe administration more challenging than injectables. And first of all, unlike injectables or tablets, you need a bulky, very sophisticated setup to deliver that to the patient. Now, just as a interesting fact, we don't really have a very good understanding how it applies to all anesthetics, whether they are injectables or inhalant. But specifically, in terms of isoflurane and sevoflurane, we believe those molecules will get stuck in the lipid bilayer or in the cellular membrane area and interfering with ionic conductance, and that will lead to neuroinhibition, therefore anesthetic effect. So whoever comes up with a lot more precise mechanism of how anesthetics work, obviously that person or that group will earn Nobel Prize. But we are not there yet. Because modern inhalants are pretty much now exclusively mm, eliminated by only one organ, that are lungs. We don't have to be worrying about the potential of overdosing of what we administer in hepatic and renal patients. On like even for propofol, we know it has extra hepatic metabolism, and yet if the patient doesn't have a good liver, it still will have the prolonged effect, and also more exaggerated drug response reaction. Um, and the drugs like ketamine are also heavily dependent on the kidney for its excretion, and yet uh, if the patient doesn't have a good renal elimination process, because they either have one kidney or both kidneys are not fully functional, then you are going to have exaggerated drug reaction too. So unlike this injectable like propofol and ketamine we just made as an example, isoflurane and sevoflurane, they absolutely go through, they don't go through hepatic or renal uh, metabolism and elimination. We're talking about less than 1%. There is some for sevoflurane, but it's still less than 1%. So you can just pretty much consider that just negligible and insignificant. And so even for prolonged duration of anesthesia on those patients, obviously they're going to have an extremely rapid recovery, which is a good thing. Having said that, why can we just not use inhalant alone then? Well, the problem with the inhalant is that, like I said, they are cardiovascularly very, very depressant, even at clinically useful dose. So you should make sure you spare the inhalant drug administration as much as you can. And how can we achieve that? Neuroleptalgia, and neuroleptalgia is simply a coin word between neuroleptics and narcotic analgesics that are combined together. They produce a good degree of sedation and analgesia, and it's essentially what we call pre-medication. And you also add the propofol, alfoxolone, ketamine, etomidate, whatever your choice of injectable induction agent is. All those put together, the term is called balanced anesthesia. So you practice balanced anesthesia to make sure you end up using as little inhalant as possible, so that the blood pressure is tolerably acceptable level. We accept mean arterial blood pressure above 60 millimeter of mercury as acceptable hypertension, and therefore maintain the patient at that level throughout the 2-hour or 3-hour surgery. Obviously, in awake patient, that's just way too low, and then you'll be just very, very concerned about that level of the blood pressure. But under general anesthesia, we are okay with it. Because once we stop administering, they will bounce back their cardiovascular depression and come out of it. So just as a broad sketch understanding between the inhalant anesthetic maintenance technique or injectable maintenance of anesthesia technique, let's just look at the compared advantages and disadvantages. So something disadvantageous is that it is bulky setup. You need like a breathing circuit, oxygen flow meter, vaporizer, oxygen gas tanks, and pressure regulator, and so essentially it's expensive and sophisticated. Whereas injectable drug, all you need is the drug itself, whether that's propofol or Voxelone, hypodermic needle and syringe, and then you can maintain anesthesia as long as you keep giving it to maintain that for 2 hours. And you can obviously maintain a lot more elaborate setup with a syringe pump, but it's still less bulky. Syringe pump are small and compact for continuous rate of infusion for 2 hour maintenance. Actually, that's not very uncommon in human medicine. In human medicine, they have something called computerized target control infusion, TCI. What it is essentially, they place electrode around the head of the human patient to assess EEG, electroencephalogram, to assess anesthetic depth, and then that gives continuous feedback to the drug concentration estimated in the patient's body. And then obviously, if the EEG recognize the patient is light, then it will increase the infusion rate of the syringe pump, and vice versa. Veterinary injectable TCI is not it's not mainstay. It's inhalant anesthetic maintenance that is mainstay for us at this point. But in human medicine, that's slightly different. Good side of the inhalant technique is that because you need intubated animal to administer isoflurane or sevoflurane, their airway is protected. And also you can regulate the oxygen enrichment. The room air is 20% of oxygen, so you can switch that to 100% of oxygen easily since you have intubated animal. Injectable technique, they don't really need intubated animal, so that's not really by default an advantage for injectable technique. So we're just really comparing the inhalant to injectable approach here. Control of anesthetic depth is much better with the inhalant than injectables. So injectables, once you administer into the bloodstream, the liver and kidney has to do work. Whereas inhalant like isoflurane or sevoflurane is all depend on lung uptake and lung elimination of the drug. So again, that also adds to how easy it is to eliminate the drug from the body, much easier for inhalants than injectables. Now, isoflurane and sevoflurane, they are all essentially harmful to the patient on chronic exposure. So we need to definitely take care of that excess waste gas in the operating area, which you don't need to worry about for injectable anesthetic management. I wanted to just touch on this basics about cardiac output is governed by heart rate and stroke volume, but also according to Ohm's law, mean arterial blood pressure and systemic vascular resistance is also essential underpinning about how cardiac output can change. So with the increased vascular resistance or increased afterload, it is going to reduce cardiac output. And we also have to understand that driving force of the blood that is represented by blood pressure, um, generally determine how good the blood uh, supply is. So generally speaking, higher blood pressure, higher blood supply to the rest of the body, and then um, that will alter the drug metabolism and elimination. Obviously, the higher the blood goes to the liver, and the higher the blood goes to the kidney, um, or the lung, the faster the drug will be cleared out of those organs. So the shorter duration of the drug effect. Blood volumes are important in a sense. How we look at the drugs distribution in the rest of the body when they are introduced to the body, and when they are staying in the vascular system longer, that will result in a longer duration of anesthesia, and therefore we need to understand how we can regulate the drugs trapped in the vascular system, and ensuring that to our advantage in making sure the patient recovers from anesthesia, or at least in a fine-tuned way, how we can regulate the anesthetic depth to our advantage. The distribution of cardiac output is relevant in our understanding about how the drug gets also eliminated from the vessel-rich group organs like brain, liver, kidney, heart, and lungs. And we know since propofol, alfoxylone, etomidate, ketamine, all these induction agents, when you administer them, they'll rapidly increase the concentration in this vessel-rich group, but then they will also rapidly disappear from this group as the drug continuously migrate from now this vessel-rich group to the second phase, where now blood supply is distributed to a group called muscle group, and in that regard, inhalants also fairly similar. They rapidly reach the high concentration in the vessel-rich group, but then they will also redistribute their concentration in the vessel-rich group to the muscle group as time goes by. So in a way, it's same process, except that inhalants are much faster in clearing out of the body compared to injectables, which is to our advantage. I guess sometimes it could be disadvantageous if your goal is to keep the animal maintained under anesthesia for the next 5 minutes, and sometimes that's why you get frustrated when you hope that the sevoflurane will still stay there for the next 5 minutes, and yet it was so rapid in getting clear, and the animal jumped off the table at the time of the nearing the end of the procedure. So In that regard, it could be disadvantageous aspect of a drug that can be extremely rapid in changing the anesthetic depth. So we went over ideal components of injectable anesthetics. Similarly speaking, there are some overlapping ideal characteristics. Non-explosive is not, though. This is gas specific. The reason that you want non-explosive inhalant anesthetic is obvious. It's a safety. There are drug called cyclopropane that used to be used as an anesthetic, and that's explosive. Non-flammable. Remember ether? Ether is very flammable, and in old days, people didn't have electricity. Electricity was fairly modern invention by Edison. I'm sure you know that. You heard about Edison, the famous American inventor who is responsible for many inventions, including light bulb. So in the old days, it was all candle and light. And then next to that candle and light, ether was used. So burning down the hospital was not uncommon, actually. So obviously you don't want that flammable gas. Fortunately, isoflurane and sevoflurane, they are not flammable, non-toxic. That goes without saying. Whether that's injectable or inhalant, potency is important for both drugs. Pleasant to inhale, that's more of an inhalant drug. Which one is not as pleasant as inhale between isoflurane and sevoflurane? Which one is more pleasant and which one is not? So isoflurane is not as pleasant as sevoflurane, something that you should be aware when you do a face mask induction for dogs and cats. Safe with carbon dioxide. So just going back there, isoflurane it's not as pleasant as sevoflurane, but it's also slower to induce anesthesia compared to sevoflurane. So it's a no-brainer that you should use sevoflurane for anesthetic induction, mask induction for dogs and cats. All right. So the next thing was safe with the carbon dioxide absorbent, of course. Minimal organ depression, of course. Low blood gas solubility. Now, this low blood gas solubility threw off a lot of people. When I was first encountered with this, I had a hard time of understanding this. Is that so? If the drug can be absorbed in the bloodstream fast, why can't that be an effective drug? You know what I mean? In fact, it's a totally opposite for inhalant. It has to be absolutely not soluble in blood to be effective. So we'll go a little bit about that in the coming slides. Anyway, minimal metabolites, of course, good analgesia, good shelf life, cheap to manufacture. All right, good enough. Goodell is obviously a clinician who founded the important medical information about how we assess different anesthetic depth utilizing ether on cats. And remember, ether is very slow in inducing anesthesia, so you can absolutely record the change of eyeball position, from central to medial ventral, back to central, pupil size, the pattern of the breathing from irregular, regular, absolutely jerky, and diaphragm and intercostal muscle gets depressed. Palpebral reflex changes and corneal reflex changes and all that. So he had fortune of defining all these, 4 stages, and the stage 3 subdivided into light plane, medium plane, and deep plane with the ether. But modern inhalants like isoflurane and sevoflurane, they're so rapid in progressing from all this stage 1 to stage 4. You can't really see a lot of these changes like you would have done with the ether. But still, let's say you have a snapshot of isoflurane anesthetized dog, and then you look at their eyeball position, for example, and then the pupil size, which happened to be like a medium plane too. Then still you can relate. Okay, the animal is in the medium plane. You may not see as readily changing the anesthetic depth from medial ventral eyeball back to central position as you dial up or dial down, but still it's important that you still get familiar with that chart, particularly medium plane of stage 3. Obviously, at the top of Mount Everest, you need an oxygen tank, enriched oxygen tank, to survive. That is because, the atmospheric pressure is so low at the top of the mountain. The partial pressure of the oxygen now becomes from whatever in the sea level to the third of that, and that means the patient cannot really survive. They become so hypoxic. So oxygen is critical in survival of the anesthetized patient, and now we utilize oxygen as the single what we call carrier gas, and you can see it has to pass through vaporizer, and that vaporizer now needs to mix the oxygen with whatever vapor of your choice. If it is sevoflurane, let's say it was sevoflurane. So the sevoflurane, the MAC value, the minimum alveolar concentration for sevoflurane is 2.4%, and isoflurane is 1.2%. That means sevoflurane is half the strength of isoflurane in potency. In other words, isoflurane is twice more potent than sevoflurane to maintain the anesthesia in patient, whether that's dog or cat or human. They are absolutely universal. So sevoflurane, anywhere between 3% to 4% will be now delivered to the anesthetic circuit, and the patient will get delivery of that through ventricular intubation, and then it gets continuously regulated since you are administering the sevoflurane in oxygen throughout the surgery. So as you administer whether isoflurane or sevoflurane, there are some elements that will change how you adjust the vapor setting in induction, maintenance, and recovery phase. Now, if you Google anesthetic uptake, You can see that they're governed by these three factors: solubility, cardiac output, and partial pressure of drugs during the inspired and expired phase. And P bar just represents where you are at altitude. So you can pretty much ignore that for practical purposes, because that's not going to really matter in clinical sense unless you are in Mount Everest. Now, let's say we also want to, beyond those three factors that will govern how rapidly the drugs get delivered, from vaporizer all the way to the brain of the patient. Practically, we want to speed up that process. Is there anything that we can do? Of course, there are something we can do. And increasing oxygen flow rate, increasing vaporizer setting, and ventilation all will enhance the anesthetic delivery of given drug to the patient, and therefore deepening of anesthesia. And that factor is critical for your practical management, because essentially when there is a situation when the animal is trying to wake up on the table, then you are going to not only increase the vaporizer setting, but you're also going to increase the oxygen flow rate, and then also increase the minute ventilation. Minute ventilation is the combined concept, not just increase respiration rate, but also tidal volume. So it's no use you increase your respiration rate to more efficiently deliver anesthetic, and that you don't deliver enough tidal volume. So you don't want to miss that aspect of mismatching. So you make sure that you always refer delivery of inhalants with the a term called minute ventilation is increased rather than respiration rate, or just simply telling tidal volume is increased. Okay. Okay, so we already touched upon this about how the inhalants mimic the injectables in change of their drug delivery into vessel-rich group to muscle group, and down the ladder you have now fat group and vessel-rich group. But what's important here is the concentration in the alveolar and the concentration in the vessel-rich group, which is brain, are essentially very, very similar and very close, and that's what matters, because it's the drug concentrated in the brain that will have anesthetic effect. So we're fortunate that inhalants will very rapidly deliver the drug concentration necessary in the brain. Now, minimum alveolar concentration, we know for sevoflurane was 2.3 and ISO is 1.3. And the higher the MAC value, the less potent they are. It's useful to know, at least for isoflurane, sevoflurane, do not worry about other agents that much. What is vapor pressure for these drugs? Essentially, the higher the vapor pressure is, the more readily they become from liquid to gas form. So, or I should say vapor, because they're not really gas. Sevoflurane and isoflurane, like I said, are the most two commonly used in veterinary medicine. So it's important that at least you know that they're not very far apart between the two. Isoflurane is 240, sevoflurane is 160. Having said that, if you somehow feels like you want to save the money by not purchasing sevoflurane vaporizer, thinking that you can utilize isoflurane vaporizer to deliver sevoflurane, then you are so wrong. Okay, do not ever attempt that. You will kill the patient. Um, since isoflurane is only calibrated, isoflurane vaporizer is only calibrated with a 240 millimeter of mercury of isoflurane. You add 160 less volatile sevoflurane into the isoflurane, it is going to increase the concentration of the sevoflurane coming out of the isoflurane way above than the percentage that you want to regulate on the vaporizer setting. So you can far exceed the drug that you felt like you are correctly administering for your sevoflurane drug delivery to the patient. Essentially, um, you know, don't try to save $1,000. How are we doing on time? Okay, so we got still minutes left. By definition, minimum alveolar concentration is the drug that will prevent gross purposeful movement in 50% of the tested subject to noxious stimuli. So it's not like 100% of the patient is completely immobile at that 1 Mac. It's not, it's actually 50%. So that means you will have to go above 2.4%, above 1.2% for sevoflurane and isoflurane respectively. The important thing about this is that at least 30% above the MAC, you are going to have close to 99% of the animal in satisfactory anesthetic depth. Okay. It's not influenced by gender difference, how long the anesthesia is kept, how heavy the animal is, how you know, blood pressure, high the blood pressure is. But if the patient becomes hyperthermic and for whatever reason, like hypothyroidism and hyponatremia, or they are in the influence of CNS stimulant like a doxycycline effect, it requires greater amount, obviously. That's not very hard to understand. Now, if the animal is depressed, like hypothermic, under the influence of the central nervous depressant drugs, and they are pregnant, they're old, hypothyroid, and anemic, and acidotic, and hypoxic, they require less amount. So that's, again, not very difficult to understand. So this is the part that I warned you in the beginning of this talk. It's so counterintuitive to understand why the drug that gets absorbed in the blood much more readily is actually less effective. It has all to do with how the concentration of that particular inhalant will equilibrate in the brain, the target site of this drug. That target site is the brain. It's not blood compartment. It's actually brain. So think of this as how fast for this inhalant to the desired brain concentration for anesthetic effect the faster the equilibrium it's established between the concentration in the lung or alveoli, concentration in the blood, and then concentration in the brain, the clinical effect of anesthesia will reach. So the faster the changes of these three different partitions occur, the faster anesthetic induction and therefore maintenance and recovery is. And so solubility coefficient for nitrous oxide, you can substitute nitrous oxide with a sevoflurane that's pretty close to that too, 0.5. And the drugs like halothane is 2.3. Isoflurane is, I think, about 1.5. So what it essentially is, okay, the higher these drugs can migrate into the blood, the longer it takes for this drug to, for this drug to equilibrate the concentration in the gas phase, blood phase, and the tissue phase. So gas phase being in the lung, blood phase obviously in the bloodstream, tissue phase in the brain.
Dr. Lee, I had a question.
Yeah.
Okay,
yeah.
So is it like safe to say that the more soluble a drug is, the more potent it is? Or is there no correlation?
There is some correlation to that, but it's also not very well correlated. For example, nitrous oxide is similar to sevoflurane in blood gas solubility, like I said, and yet their potency is like miles apart. Just what's important here is to understand why solubility will interfere with the speed of the induction and recovery, rather than worrying about the MAC value, whether the MAC value is 1%, 2%, or 100%. Because the potency, at the end of the day, potency is all to do with how you need to administer the amount of the drug. And that's easy to do. All you need to do is just adjusting the vaporizer setting. Whereas the solubility and influencing the induction has far more implication, like not just the blood volume, but also the gas flow rate, and also concentration that you dial. So it is more important to understand the blood gas solubility is more critical to adjust the speed of the anesthetic induction and recovery, and therefore anesthetic depth control. So I think in the interest of time, I'm just showing you the slope also represents how rapidly the drug equilibrates between these three phases, knowing that nitrous oxide, desflurane, sevoflurane being the highest in this represented graph. That means faster induction, followed by isoflurane, and then halothane, methoxyflurane, and then ether, obviously. It will be the bottom of it too. It's not there, but and then again, in order for you to provide faster induction, you need to increase the oxygen flow rate. That graph represents that. Now, cardiac output is totally opposite. The higher the cardiac output, the slower the induction is. The lower cardiac output, the faster induction is. Okay, so this is very dangerous because essentially inhalants will keep depressing cardiac output as you deepen anesthetic depth. and yet the speed of the induction will accelerate as the animal reduces cardiac output. That's why you need to understand this. Depressed animal will have a faster induction and the faster change of anesthetic depth, and to the point where it will go to irreversible damage to the tissue, like a brain, all the plasma-rich group. Okay, so I think I should just stop here to allow maybe a couple of questions to you. The rest of the slides are just essentially same spin-off concept about how deepening of anesthetic depth will have a profound cardiovascular depression, like low blood pressure, and that may alter also anesthetic safety, because that will lead to faster induction and change of anesthetic depth to the point making the animal extremely hypertensive. Okay, so it's 2:55. I can literally have one or two questions from you, but then I have to let you go so that you can go and join I believe Dr. Anglis or Dr. Pressler right after this.
Just to make sure, did you say slower the blood flow is faster the induction?
Yes, that is because the equilibration between the lung, blood, and the brain, the target organ, is going to be much faster with the less blood available to absorb and then get distributed to the brain. So the slower or the less blood available to factor into those equilibration process, the faster the drug effect or induction is. It's counterintuitive when you first hear it, but then as you just keep thinking about it, it makes better sense. So, oh yeah, the less blood amount for the drug to cross and then equilibrate, the faster it can reach to the brain. Okay, so think about that way, because it's really the brain that makes the anesthesia as is. Because, the drug has to work on the brain. Well, for anesthetics, not for all the drugs, but for anesthetics, definitely it's the brain that matters. Okay, ladies and gentlemen, it was good catching up with you. I'm going to stop sharing so that you can all have a great rest of the day. Stay well and safe. Ciao, adios, bye.